30-year-old female presents with amenorrhea. On examination, she is obese. There are acne and hairs similar to male beard. Investigation shows high blood sugar. She also complains that she collides with door and also people in the crowd frequently these days. How will you approach to this patient? Cushing syndrome. It is a metabolic condition in which there is high plasma cortisol level, which leads to glucose intolerance, hypertension, and obesity. Classification. Basically classified into exogenous and endogenous causes. Endogenous causes include adrenal, pituitary, and ectopic causes. Adrenal causes include bilateral adrenal hyperplasia, adenoma, and carcinoma. Pituitary causes include pituitary adenoma, which is the most common endogenous cause of Cushing syndrome, and the most common overall cause of Cushing syndrome is exogenous steroid use. Ectopic ACTH is produced by small cell carcinoma, breast cancer, carcinoid tumor, and medullary thyroid cancer. Clinical findings and complications of Cushing syndrome can be summarized by the mnemonic Cushingoid, where C stands for cataracts, U for ulcers, S for skin changes like striae, bruising, thinning, and ulcer, H for hirsutism and hypertension, I for infections, N for necrosis, G for glycosuria, O for obesity and osteoporosis, I for immunosuppression, and D for diabetes. Other typical features are moon faces, buffalo hump, muscle weakness, especially the proximal one, poor wound healing, purpura, and amenorrhea. Diagnosis. Low dose 1 mg overnight dexamethasone suppression test is used to rule out the diagnosis of Cushing syndrome. 1 mg dexamethasone is given at 11 pm and plasma cortisol measured at 8 am. Normally cortisol should be suppressed, but in Cushing syndrome cortisol remain elevated. An abnormality on the 1 mg overnight test should be confirmed with a 24-hour urine-free cortisol. The 24-hour urine-free cortisol is more accurate and is the gold standard for confirming or excluding Cushing syndrome. A third screening test for Cushing is the midnight salivary cortisol. In normal patients, cortisol is at its lowest at midnight. In Cushing's patient, cortisol is abnormally elevated at midnight. After confirming the diagnosis, ACTH level is measured, which is low in adrenal and exogenous cause and high in pituitary and ectopic ACTH secreting tumor. To distinguish between pituitary cause and ectopic ACTH, a high dose 8 mg dexamethasone suppression test is done in which cortisol is suppressed in pituitary cause but remains elevated in ectopic ACTH producing tumor. Lastly, a CT or MRI of head, chest, and abdomen is done to look for pituitary, lung, and adrenal lesions respectively. Now this table shows two important things. First, ACTH, which is decreased in exogenous steroid use and adrenal cortical hypersecretion, and it is increased in ectopic ACTH secretion and Cushing's disease. The second thing is dexamethasone suppression test. In low dose dexamethasone suppression test, cortisol level is increased in both Cushing disease and ectopic ACTH secretion, but in high dose dexamethasone suppression test, cortisol level is low in Cushing's disease, whereas it is still elevated in ectopic ACTH secretion. The differential diagnoses include hypothyroidism, diabetes mellitus, polycystic ovarian syndrome, and acromegaly. In hypothyroidism, patients present with weight gain and muscle weakness, same as in Cushing syndrome, but this can be confirmed with thyroid function test. In diabetes mellitus, patient present with obesity and hyperglycemia. A fasting sugar and HbA1c confirms the diagnosis of diabetes mellitus. In polycystic ovarian syndrome, patient presents with amenorrhea, hirsutism, hyperglycemia, and obesity. Here, a USG of the abdomen and pelvis is done to look for cyst in the ovary. In acromegaly, patient present with glucose intolerance, weight gain, and visual field defect. Insulin-like growth factor 1 is measured to diagnose acromegaly. Treatment. Treatment of exogenous Cushing syndrome is gradually withdraw and stop glucocorticoids. In endogenous Cushing syndrome, surgical resection of the source is done. Permanent hormone replacement therapy to correct deficiencies after treatment or resection of the primary lesion is necessary. Now must remember points. Remember the mnemonic Cushingoid. In Cushing disease, cortisol secretion remains elevated with low dose 1 mg dexamethasone test, but is suppressed with the high dose 8 mg dexamethasone test. In ectopic ACTH, even high dose dexamethasone does not suppress cortisol secretion. Now back to the case. This patient seems to have ACTH producing pituitary adenoma, causing features of increased adrenal cortex hormones, also called Cushing's disease. High plasma ACTH, high plasma cortisol, and MRI of head will confirm the diagnosis. Treatment is surgical resection of the tumor. An important clue here is visual field defect, which points toward pituitary cause.